Obsessive compulsive disorder, or OCD, is notoriously hard to treat. Although for most psychological disorders, common factors such as the therapeutic alliance are more important than the particular approach, in the case of OCD, there is substantial evidence that cognitive behavioral approaches are the most effective treatments we currently have. In this demonstration, you're going to see renowned anxiety disorders expert Reed Wilson work with Bob, a client whose OCD is severely impacting and limiting his life. Although Reed's approach is similar to the popular model of exposure and response prevention, he presents a subtle but significant variation of ERP. Rather than helping a client to tolerate the anxiety associated with OCD, he urges the client to move towards the anxiety, to want it. We're going to join the two of them about halfway through the first session, and what they've agreed will be 2 sessions of treatment.
This is a little ridiculous to think that we can spend like 45 minutes or an hour now and 45 minutes an hour Sunday and help you. And we totally can. I've done it lots of times before, and I don't know whether you and I'll connect with what I'm going to tell you, but it's possible. So let's see if let's see if we can build it together, and if it makes some sense to you. First is OCD's out here. Right. In other words, let's think about OCD's. You have a relationship with OCD, clearly, right? It gets in your head, it messes with you. You feel like you can't overcome it, and so you do whatever OCD asks you to do.
Right.
You know why you go out of the room and come back in? Because OCD tells you that's the only way you're going to be able to get rid of this feeling and sleep. OCD lives in people who cannot tolerate uncertainty about that theme, just about that theme. You have a lot of uncertainty. How's this workout going to go with this person, and how, all that. You're 26, you've been through all that. But regarding the content that you've got with OCD, you don't want to find out if you can not do that repetition and also fall asleep. You don't want it, because you've tried it before and you could stay awake all night. It'd be terrible. We need to do the opposite of that. Okay. So what we want to shift is your relationship with OCD. OCD only lives in you if you respond properly, which is, I've got to get rid of my anxiety, and I've got to get rid of this preoccupation of this word or image or whatever. Let's flip that. What's the opposite of I've got to get rid of my anxiety?
I want it. I want my anxiety.
And I want to keep it?
I want to have my anxiety. I want it to stick around.
Okay.
I want to feel it.
My uncertainty? I've got to get rid of my uncertainty? What's the opposite of that?
I'm never going to be certain. And that's okay. I want it to be that way.
Okay. So
I don't want to be sure about
the middle
anything.
is it's okay. The extreme is I want uncertainty. Okay. So we got that piece. That seems like a crazy thing to think and do. We're going to make one other shift, which is it's got a whole, you just asked me again when I say things that seem confusing to you. So what I want to do is the opposite of what OCD requires. OCD requires me to resist having that thought and try to get rid of it, and resist feeling anxious and try to get rid of that. So I'm going to I want to have the opposite of that, which is I'm going to go toward being uncertain and toward being anxious. Throughout the session, I've been listening for how Bob addresses the symptoms, and he clearly views the disorder as an entity outside of himself, doing harm to him. So it's a very easy step to sharpen that distinction, to convey that our intervention will include externalizing and personifying OCD as his challenger. This is an essential task
as strategic treatment begins. I tell him that his job is to do exactly the opposite of what OCD demands. Then I quiz him.